patients have a Blue Cross Blue Shield or Cigna healthcare card, and they have a whole network of surgeons to pick from, but they have no way to pick the right surgeon with the best outcomes, very specific to their own condition. So that's what we're trying to fix today.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. Today, we virtually visit Rockville, Maryland with SurgiQuality CEO and author Dr. Sanjay Prasad. SurgiQuality helps surgical patients connect with best-in-class surgeons who work in a cost-efficient environment. Sanjay, welcome to the Business of Healthcare podcast.
Thank you, Bob. Thanks for having me on, and I'm looking forward to talking to you today.
Well, we have featured several authors on the business of healthcare. We had Dr. Marty McCary with his book, The Price We Pay, and Dr. Vivian Lee with her bestseller, The Long Fix. Each of those highlight many of the problems that we are seeing that are predominant within the healthcare system. And today, we want to talk about your book, Resetting Healthcare, Post-COVID-19 Pandemic, the Patient Handbook, which is written for us, the patient. But before we do, I'm always interested in your background and the motivation for creating and delivering your message. Tell us your story.
Well, Bob, thank you so much for asking. I was born in 1961. I came here in 1962. And I was a year old, my family of four, and we came from India and traveled by ship, hard to believe, 30-day journey. And my mom tells me the story about a month ago that we came here looking for a solution to a healthcare problem in the family. And I was stunned. It seems like everything goes full circle because I became a surgeon in the Washington, D.C. area, practiced for 30 years or so. And now I'm trying to help, millions of patients connect with the best-in-class surgeons for their condition.
Well, the topic today is surgery. We're going to start there with surgery. I think we'll get into a broader topic of quality, things of that nature. But when it comes to surgery, let's educate our audience a little bit about surgery. And the joke that I've always heard is really not funny, but people have said, hey, there's two kinds of surgery. There's important surgery and other people's surgery, really meaning that my surgery is the important surgery. But you are a surgeon and you have a broad background of surgery. What are the different types of surgery? We've heard terms like elective surgery. Kind of educate our audience the different types that you see today.
Yeah, Bob, when I was researching my book, I found 92% of all surgeries are non-urgent. By that, I mean, it's not a condition where the patient's having bleeding or an uncontrolled or unstable situation where they need surgery right away. But 92% of surgeries that are recommended are situations where patients can pause, reassess, and reevaluate whether they need the surgery at all, whether there are alternatives to surgery, and whether they're seeing the right surgeon in terms of success rates, complication rates. So there's always this time to reassess, if you will.
Well, let's bring that into the context of this pandemic that we've been experiencing for the last 2 years now. A lot of these non-urgent surgeries have been delayed. And I'm sure that there's consequences for that. There's probably some have experienced serious developments because they've not had the opportunity to have the surgery, that non-urgent surgery at least. I guess that's good news that we've had time to think about it. What's the bad news side of that?
Yeah, I mean, the COVID pandemic, as you highlighted in 2020, all surgeries went on pause, especially the non-urgent surgeries. Patients were scared. Patients were scared to enter a hospital for fear of contracting COVID. Patients even today are very careful and want to think twice about entering a hospital setting. With social distancing, with masking, with mass vaccinations, the whole healthcare system is starting to open up. Patients are starting to reschedule those surgeries. It's a great time to reset healthcare as we know it today. The result of the 2020 pause was that there were many breast masses, for example, that weren't biopsied. There were some colon tumors that perhaps weren't diagnosed through colonoscopy. We don't know the full extent of the damage that was done yet. We hope that we won't see much damage, but my fear is that we'll have patients with more advanced cancers, whether it's breast cancer or colon cancer, in the coming years. We'll see those studies as they come forward.
So being a surgeon, Sanjay, I would think that if you see a patient, you might be inclined to say you need surgery. Many surgeons might do that. The point I'm trying to make here is that I read in your book that 30% of surgeries aren't actually needed. Can you expound on that a little bit?
Yeah, it's pretty astonishing. When you study the literature, 15 to 30% of surgeries, depending on specialty, are unnecessary, can be managed through alternative means, whether it's physical therapy instead of a knee operation, or whether it's going to a more conservative option, such as using a gastroenterologist to remove a cancerous polyp, as opposed to going to a colorectal surgeon who's going to remove half your colon. There's all sorts of other alternative options that are available. So it's a great time to reset, rethink about what's happening, the decisions that are being made for you. We're all about empowering the consumer with very important information in regards to opinions from multiple specialties, opinions within that specialty, success rates, complication rates across an array of surgeons. Patients have a Blue Cross Blue Shield or Cigna healthcare card, and they have a whole network of surgeons to pick from, but they have no way to pick the right surgeon with the best outcomes, very specific to their own condition. So that's what we're trying to fix today.
I understand that becoming a consumer of your healthcare is a very, very difficult challenge for most of us. Most of us don't pay much attention to our healthcare needs until we need them. And in terms of urgent surgery, if you're hauled off from an accident and you need immediate attention, you're probably not going to sit there and analyze things ahead of time. Most likely, you're going to deal with the circumstances that are presented to you. But when it comes to really thinking about making choices for surgery or not having surgery and going through that process of understanding the different elements, that's part of being a consumer, I believe. Is that what you're doing in this book, is trying to become a consumer advocate to let people know the things they should be looking out for, some of the traps and some of the areas that are high risk? You mentioned patient traps, patient trap A and patient trap B in your book. Why don't you share with our audience what those are?
Yeah, we call them traps for good reason. Patients develop a condition, whether it's a mass on their thyroid gland, or whether it's a tummy ache or a bad headache, or their knee hurts all of a sudden and they don't quite understand why. They go see their primary care physician. They're evaluated. They're referred to a surgeon, and this is where the problem starts. So that referral is being made really based on habit. Usually there's a sheet of specialists that the practice normally refers cases to, or they're going to, you go get referred to a specialist who's upstairs in the same medical office building. That referral is not being made on the basis of cost. That is that surgeon in network, out of network? What about the anesthesiologist? What about the facility, the hospital, the surgery center? And it's also not being made on the basis of surgical outcomes, very specific to your condition. And that's the problem we're trying to fix. The result has been that patients are getting surgery they don't need. Patients are having complications from surgery they don't need. And patients are getting referred to surgeons with not necessarily the best outcomes, leading to infections, wrong implant insertions, leading to revision surgery, scar tissue, more revision surgery, And this is the problem we're trying to address.
Well, it's a complicated set of circumstances for sure. When you stop and think about going to have surgery, all the questions that might come to your mind, what's it going to cost? Who's going to do the surgery? What's my recovery? What can possibly go wrong? And you point out a number of things that can go wrong in a hospital. You identified 5 different things that can go wrong in a hospital. And when you read about some of the reports from Leapfrog and others about mishaps that happen in the hospital and the volume of those mishaps, that would discourage anybody who knew that information to really think twice before going into that environment. You reference MRSA. MRSA is an acronym for, I'll let you define MRSA for the audience, but that was a big threat until COVID came along, and that's not talked about too much right now. But how do you make people understand the circumstances to avoid and the decisions they need to make when they go into a hospital environment?
Well, you said it really well. MRSA is methicillin-resistant Staphylococcus aureus. It's an infection that initially was nosocomial, meaning patients only got it in the hospital setting. It gradually became community acquired, where you could get it in the community, at whether it's in a locker room, in a stadium, in athletic facilities and gyms across the country. What's really interesting is that MRSA was known. It was known and discussed, and people were aware of it, but it still didn't push people to start to ask difficult questions. That is, what is the MRSA rate, the infection rate at this hospital, this facility? They weren't all that concerned with MRSA, but COVID is a whole different animal, right? So coronavirus, all of a sudden, because of all of the horror that's happened with jillions of families throughout the world, including my own, has really caused us to think about infections, and not just bacterial infections, but viral infections and the impact that they can possibly have. And, of course, these hospitals were taking care of the sickest patients with coronavirus. There was trepidation on the part of the patient to enter these facilities for fear of contracting the virus. But it's certainly heightened the awareness of infection rates in hospital settings, in surgery center settings. It's all of a sudden opened our eyes, hasn't it?
It has. At the University of Texas, Dallas, we have a couple educational programs. One is the Alliance for Physician Leadership, which has a room full, usually 50 is the top max number of doctors from around the country that come in. And we learn a lot about quality. We learn a lot about value-based healthcare. We also look at things like strategy and things of that nature. And part of that is, in strategy, we talk about branding. And in your book, you uncover several different myths. And these myths are really related to hospitals and outcomes and how they brand themselves and the newsletters they write. And, one thing, does a name brand medical training mean better outcomes? That's a myth that you talk about. I'd like to kind of go through some of these myths, because I think when people start to understand the truth behind these myths, they may think differently and become a better consumer. So patients can rely on online research is one of the myths that you have. Awards, ratings, rankings, and recognition make a difference. So you know what the myths are. Why don't you kind of bust some of those myths for us, Sanjay?
Yeah, and I've got a lot of flack over that chapter on hospital newsletters. So let me start there, because I think hospital newsletters are obviously doing a tremendous service. There's no question, right? Hospitals are engaging with communities. They're developing support groups for these communities. They're showcasing surgeons. They're showcasing new technologies. We get that. That's terrific. But patients shouldn't jump to conclusions. That is, it shouldn't be misunderstood that just because they're embracing new technologies, that they're necessarily the best at certain procedures and quality outcomes. Because I think that quality outcomes are all related to the surgeon, the surgical technique, the surgical decision of when to take a patient to the operating room, how the surgery is done, the approach that's made, the postoperative care that's delivered. It's really, I think it's very surgeon specific. And I think hospitals today have focused on, and you can talk about all the brand name institutions that are out there. When they report quality outcomes, they're reporting aggregated outcomes. And I think aggregated meaning all of their surgeons in a department are reporting in an aggregated way how many surgeries they're doing, what's their success rate, what's their complication rate. The consumer needs more transparency because the outcomes are related to the specific surgeon who's taking care of you. So what we're asking for in a very polite way is please provide us your surgeon-specific, procedure-specific quality data. Let's be more transparent with our patients. Let's give them the respect that they deserve. Let's give them the information that they need. Let's give them the education to understand some of those measures. That's what our concierge system does. And let's understand that when you have their buy-in, and that's so important, when you have their buy-in, good things happen. There's no question.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Well, we see these reports, and they're not talked about very often, but annually, 250,000 to 300,000 people die in hospitals due to errors. Wow, if that was headline news, you'd have a long list of questions before you went to a particular hospital. But the things that you mention is, there's things that are done wrong, commissions that are actually practiced wrong. And sometimes you forget to do the right thing. You have an omission. And communication. Wow, that's a key area that can cause a lot of problems. Context. You bang your head up and you mess your shoulder up and you go home and take a lot of ibuprofen for the shoulder and you induce a brain bleed. That's just a context issue. Then diagnosis. How do you go about diagnosis correctly? Those things are all educational. And I'm not sure how you go down a checklist with an organization who's going to answer those questions for you. So what's the suggestion for the consumer to have a methodology to analyze that, at least give it a deeper view than what they currently do?
And you're absolutely correct. Medical errors are the third leading cause of death in the United States. It's hard to believe. I mean, there's heart disease, there's cancer, and then there's medical errors. And these are human errors. And sometimes they're human errors of communication, or I forget to tell my patient what to do postoperatively. These are things that I think will get better as technology improves. And there's no question about it. As our communication technology improves, technology, I think, is the key to reducing those errors. And we've got to do better than what we're doing. Patients don't have a way of comparing one institution versus another in terms of medical errors. And I think that's what you're trying to get at. But what they do have a method with SurgiQuality to compare one surgeon against another for the specific procedure that they're about to have in terms of outcomes. And that, I think, is a major advance in from where we are today.
Yeah. So you mentioned transparency, Sanjay. Transparency. There's regulations that are being processed right now where hospitals have to provide transparency on their pricing. A lot of the hospitals have not complied with that. About 30% have. There's a penalty for not doing it, and we're trying to get transparency in a variety of ways. In our classes at the university, we talked about Surgery Center of Oklahoma, where you can go online and see exactly down to the penny how much a shoulder replacement is or how much a knee replacement is. And that's quite disrupting the status quo. I mean, you can go out there and actually find the quality that's related to that. Do you see that becoming a trend where people will be able to understand best practices and pricing and quality more clearly going forward?
Yeah, and I think it's really important, right, to know what the pricing is, especially for employers who are self-insured. But I think for the vast majority of people, Bob, who have a Blue Cross card, they know what their deductible is. They want to go see the best surgeon. But certainly what Keith Smith has done at University of Oklahoma, not University of Oklahoma, but Oklahoma Surgical Center, is a major advance. They're providing transparent bundled pricing. We're still working with them. They're on our platform. We still want to be able to get them on our platform in terms of procedure-specific outcomes across their array of surgeons. I know they'll be very interested in that and showcasing their surgery center as well. So we're really excited to be able to work with them.
So this whole concept of value-based care, it really kind of got kicked off back in 2008 with Dr. Berwick with the IHI, the Healthcare Improvement Institute, Triple Aim. And just for the benefit of our audience, most have heard about it, but it's really improving the patient experience, getting the best care you can, and improving population health and reducing the cost. And then a little bit later on here, we've come up with not the triple aim, but the quadruple aim. And that really brings in another dimension to get the performance of the healthcare system better by the providers. And we know a lot about patient experiences, short time with the physician burnout, extra long hours, all these different issues that really are centered around the provider, the physicians, the nurses, all the people that are in that delivery process. And so now we're really trying to add that into this quality measurement called the quadruple aim. The question becomes this: how serious are the issues that some of these physicians are going through? Are some of them aging out? Are some of them qualified to use the best tools, the best technology? How do you go about differentiating whether someone uses one method versus another method to do the surgery, and the outcomes might be different? How do you educate people along that line?
Well, I should really talk about what SurgiQuality is doing, and because I don't think we've really prefaced that and talked about it, but SurgiQuality is a personalized concierge service that handholds you through that healthcare process. How do we do it? Well, you are referred to a surgeon. You're told you need surgery. You've had diagnostic tests, imaging. You've had some medical records where an orthopedist has told you need a rotator cuff repair, for example. Our concierge sources your medical records and with your permission, and we send it up to the cloud, and then we send it to multiple surgeons in your network to validate that, in fact, you do need surgery. And they can also tell you about alternatives to surgery. They also enter their past outcomes, how many cases they did last year, success rates, complication rates, and we corroborate that with their medical record and report back to you a list of surgeons have opined on your case, and you pick and choose your surgeon based on cost, but more importantly, based on quality measures very specific to your procedure. It just makes a ton of sense. What's in it for the providers? Look, we're going to Fortune 50 companies. Thousands of surgeries will come aboard on a monthly basis. They're getting access to cases they wouldn't have gotten access to, number one. But also there's another hidden aspect that's a major benefit to providers. And that is these cases are peer reviewed for necessity. So a number of surgeons have told the patient that they do, in fact, need surgery. It's validated. So when a surgeon operates on a patient that has been peer reviewed, they're reducing their malpractice risk, no question. They're reducing the chance of a sham peer review of an insurance company coming back and taking money away 6 months later, a year later, 10 years later for a case they did. It just makes a ton of sense to use the platform. And I'm sure with time, malpractice premiums will drop. There's no question. It's just a matter of time.
Well, that sounds like a great way to have a coherent prognosis Kind of like the way the Mayo Clinic does it. You have several different, people peer reviewing your particular environment like that. That's incredible. I think the name says it all, that you have SurgiQuality. And that's a logical, straightforward process that should become a best practice and that people would understand. The whole idea here is to improve the quality every day, make things more consistent, make things more predictable, make things more cost effective. At some point in time, there's going to be a financial debt reset in this country, and it's going to have a big impact on healthcare. Healthcare, as we know, I think it just surpassed Germany in total of cost. So it's China, Japan, and then U.S. healthcare GDP. So we're going to see a lot of changes take place that deal with the cost aspect of healthcare. COVID was bad. I think we all agree with that. Why was COVID good in terms of bringing us to a reset model? What's your thoughts on that, Sanjay?
Well, the pause, also was the birth, really, I will say, of telehealth, right? And virtual visits. Now, you can see any doctor on a virtual visit, and I think that has been monumental. And it's not going to fade away. It's not a fad that's going to fade. This is going to persist. It's going to be augmenting a medical practice going in the future. And I think it's a good thing because you can take care of patients remotely. They don't have to take time off from work. It just makes a ton of sense.
Well, Sanjay, I must tell you that I enjoyed reading your book. It was about 100 pages. It was a page-turning experience, so educational, appropriately named the Patient Handbook, Resetting Healthcare Post-COVID-19 Pandemic. Thank you for sharing that with us, and thank you for being on our podcast today. I think there's a lot of value to be gained here looking at this process going forward.
Thank you, Bob, for having me on your show. A real pleasure to talk to you and to get to know you. Thank you.
You're most welcome. Thank you. Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.